Thank you. Assalamu alaikum. So I'm going to speak on, actually I'm going to go backwards because the symposiums that you've heard in the previous symposium have all been about the drugs that we should be using for diabetes. However, my task is actually to make you understand diabetes better. So these are my disclosures. I have received honoraria for lectures from Novo Nordisk, Sanofi, Lilly, and I've also received grants from Pfizer and Procter & Gamble to do grants, to do studies. I have also, and I put my hand up, received a large honorarium from Getz Pharma to speak, and I've been on a tour actually across the country to speak. And this is the last of my talks before I go back to Qatar tonight, inshallah. However, all of my money that I've received is actually going to go to a foundation called the Raybar Education Foundation, which is for a school for orphans in PKP. So I start with a quote from a famous book. It was the best of times, it was the worst of times, it was the age of wisdom, it was the age of foolishness. Dare I ask our honorable minister to tell me what are these opening lines from which book? Name, I won't. So this is actually the opening lines from A Tale of Two Cities. And A Tale of Two Cities. Dickens? Okay. Yeah. So the reason I put this up because I think actually it's relevant to what I'm talking about today. That we are now living in an age where, as you've heard from the previous speakers, we have drugs. We have drugs that started with insulin, 1922, 100 years ago. We had sulfonylureas, we had biguanides, we had all these drugs, and then we kind of slept for a long time. But now you can see we've got more than enough drugs. And I think the key here is not about which drugs we use. It's actually making the diagnosis. So Otto Eichenschimmel said, the best physician must fail if his treatment is based on a wrong diagnosis. And Gandhi said, a correct diagnosis is 3/4 the remedy. So that's the key to my lecture. Whenever you see a patient in front of you, don't just think that they've got type 1 or type 2 diabetes, right? We need to start thinking differently now about diabetes, because if you do, then actually you will use the correct treatment for that patient. So back to basics. If we think about diabetes, there are two main types we think about, type 1 and type 2. But we need to be aware of further subtypes, and I'm going to talk about the subtypes of type 2 diabetes, but to set the scene, I'm going to take you back in time and actually talk to you about two other subgroups which have been described, as the person who introduced me said, over 30 years. And these are maturity onset diabetes of the young, 2 to 5%. And the young is the key here. Why? Because if you have a young person who's diagnosed with diabetes, invariably, 99% of the time, what will you do? You will put them on insulin. And you will put them on insulin for life. And what I want to get the message across is that there is a proportion of people in there, even if it's only 2 children out of 100, who do not need insulin. They need a very old drug that works very effectively. Then the other group is this, which is LADA, latent autoimmune diabetes of adults. Again, the operative word here is autoimmune. And that tells you that this type of diabetes is actually like type 1 diabetes, but different. Same but different. So let's go back to type 1 diabetes. We know it peaks at puberty. We know most patients present before the age of 40. But did you know 1 in 5 people develop type 1 diabetes over the age of 40? And in fact, the most famous example is Theresa May, who's the ex-Prime Minister of the UK, who at the age of 57 presented, this is when she was the Prime Minister, had polyuria, polydipsia, weight loss. She went to her doctor, who actually was some senior physician, and he said, "Ma'am, you've got type 2 diabetes." And he put her on metformin and, I can't remember, maybe a DPP-4 inhibitor. 3 months later, she was admitted to hospital in diabetic ketoacidosis. Why? Because she had type 1 diabetes. And when they did her antibodies, they were positive. So we know that type 1 diabetes has a genetic predisposition. There are certain environmental factors that may drive the development of type 1 diabetes, and one of which is actually vitamin D deficiency. And we also know that the key pathophysiological basis of type 1 diabetes is that this is an immune-mediated attack on the beta cells. And therefore, one of the key features or ways of diagnosing type 1 diabetes is through looking at the antibodies, whether they're anti-GAD, IA2, IA2 beta, and zinc transporter antibodies. So there are 4 types of antibodies. An important message that I want you to take away is that autoantibodies may actually be absent in about 20% of people with type 1 diabetes. Now, does that mean that this is not an autoimmune disease? No. The antibody that is often absent is the antibody that's most easily available or widely available, anti-GAD. If you actually do the full panel of antibodies, you will find that 99% of those people actually will have an antibody positive, and they still have type 1 diabetes. So let's go back to type 1 diabetes. This is the original picture of, I think his name's Richard Thompson, the child who had type 1 diabetes. And that is the miraculous effect of insulin. So what used to happen to people before 1922 if they got type 1 diabetes? They used to die a slow death. And that slow death was about over 2 years. The physicians would give them low glucose diets, and actually they would invariably become ketoacidotic and they would die. When insulin came along, that totally transformed what we do. So if insulin is life-saving and you have type 1 diabetes, any of you brave enough to stop insulin in a patient with type 1 diabetes? When was the last time you stopped insulin in a patient with type 1 diabetes? Anybody? I have, but the patient didn't have type 1 diabetes. And that's another message. We often make the diagnosis clinically because the patient is young, they have osmotic symptoms, they might even have ketoacidosis. But the key is going back to the antibodies. Because, and this is actually a study published in Diabetes Care last year, which looked at tried to answer this question. So they had 651 people with type 1 diabetes diagnosed clinically. This is in the UK. And what they did was they measured the antibodies in these patients. So if you look, 651 patients with clinically diagnosed type 1 diabetes. So these were typical young people, osmotic symptoms, weight loss, polyuria, polydipsia, went on insulin. So these guys, what they did is they said, okay, we're going to test the antibodies, GAD, IA2, and zinc transporter antibodies. And to their surprise, they found that all 3 antibodies were absent in 1/4 of those people with apparent type 1 diabetes. So, what can you conclude from that? Do they have type 1 diabetes or don't they have type 1 diabetes? Shahid sir? Do they or don't they? May not. So what would you do? Would you stop their insulin? brave man would stop their insulin, but actually that's what they did. They actually gave the choice for these people if insulin was stopped in a quarter, right? So the brave guys stopped it in a quarter of those who had no antibodies. And what you see here actually is, in the slide, the differences between those who were antibody positive as opposed to antibody negative, okay? And the key features actually that I'll summarize for you are more of those that were antibody negative. So clinically, you don't have to do antibodies. More of them were male. More of them were older at diagnosis, so 42 instead of 38. More of those had a higher weight, 27.4 as opposed to 25. And then other autoimmune conditions. They had less other autoimmune conditions. Okay? So from a clinical point of view, you can start to already try to work out whether this patient might be autoantibody negative or positive. But then look what happens if you look at them in terms of insulin treatment. So the first column is, so they're all antibody negative. If you continue their insulin, look what HbA1c is the same. But the best and most important one is this one here, this group. This is insulin stopped. Look what happened to the HbA1c. Actually, no different to if you continued insulin treatment. So safely, you can stop their insulin, and you're talking about stopping insulin in a young person for the rest of their life, if just based on an antibody test. The other type of diabetes that I come across maybe once a year, right? It is important to be aware of this. So this is fulminant type 1 diabetes. This is actually described primarily in Japan, but then also now increasingly across the rest of the world. So this is actually a French case that was a 26-year-old Cambodian man admitted in Marseille during the COVID pandemic. And he had a 6-day history of confusion, nausea, abdominal pain, but no polyuria, polydipsia, weight loss. However, when they did his arterial blood gases, he was acidotic and he was ketoniuric. So then they measured the glucose, and the glucose came back at 60.5 millimoles per liter. However, look at the HbA1c, 6.2%. So does he have diabetes? Yes, he's got osmotic symptoms, he's got a very high plasma glucose. But then why is his HbA1c normal? Well, in impaired glucose tolerance. That's because you think that there's something acute going on. And you might think he's got pancreatitis. But actually, they did MRI, CT, PET, no evidence of pancreatic damage. Antibodies, negative. Doesn't have type 1 diabetes. Doesn't have pancreatitis. So what has he got? He's still got diabetes, but it's actually fulminant type 1 diabetes. And this is very different to the standard type 1 diabetes. And these are the features. And the difference is that in standard autoimmune type 1 diabetes, what you have is a process over weeks, months, where you get slow autoimmune destruction of the beta cells. And eventually, when the beta cells get to a certain threshold of 20%, that's when the patient comes in with being unwell, osmotic symptoms. But in fulminant type 1 diabetes, your pancreatic beta cells are perfectly normal. We don't know what happens, why it happens. Suddenly, all the beta cells get destroyed. And it's not autoimmune, and it's not pancreatitis. But nevertheless, the patient has a very high glucose, is ketoacidotic, and is very unwell. And they need insulin. So, ketoacidotic, normal HbA1c, no antibodies, no C-peptide. Next, we turn to another subtype of diabetes we need to be aware of. Why? Because the studies I will share with you show that in this part of the world, it's 3 times more common than in places like the UK. Okay? And that is maturity onset diabetes of the young. And I put this picture up for you to remember. Not because it's a pretty picture about somebody getting married, but actually, I'll share with you. So MODY is at least 2 to 5% of people. And the key here is that these people will be often people you think have got type 1 diabetes. They are the young people who you put on insulin and you've never questioned whether they'd really have type 1 diabetes. Where was it described? In England. Robert Tattersall was the professor of diabetes in Nottingham in 1974, before we had genetic sequencing, commonly used, made this diagnosis. He discovered this. How did he discover it? Purely from the clinical history. Nothing more. And the clinical history was, if you look on the photo, what you see is basically that you have 2 daughters of this woman who've got diabetes, her sister's got diabetes, and their parents, one of the 2 grandmothers has got diabetes. So this is an autosomal dominant condition where you see it. So if you ask, the key is not to just ask for family history. Because if you ask for some family history, people invariably in this part of the world will say, yeah, my father's got it or my grandfather's had it. It's young onset diabetes, so below the age of 30. And that's the key. Often less than 25, non-obese. And what is the reason why they get this diabetes? Well, it's not because they have an autoimmune destruction of their beta cells. But it is because they have a problem with their beta cells. And this is the beta cell. If you look at the beta cell, there are 2 major ways in which insulin is produced. And we saw, I think Shahid put up this in a different cartoon. But what I want you to focus on is the following. The key is that you are activating this calcium channel, okay? And you're allowing calcium to enter, which then goes to the Golgi apparatus and then causes the release of insulin. But what regulates this and this? Well, first of all, this ATP-sensitive potassium channel is an important regulator of this. And a number of nuclear substances actually regulate the release of insulin. So, which drug do we have that's been around since 1956 is a really important modulator of the potassium channel? You know it because you're just giving a talk on it. Sulfonylureas, drugs that we've actually, I say in Qatar and the UK we've forgotten about. But that is the thing that will open up your potassium channel, bypass all of this, and allow insulin release, which is the problem. So, what is it? Maturity onset diabetes. 80% are misdiagnosed as type 1 diabetes. So, to me, that's a lifetime of insulin for somebody who doesn't need insulin. Why? Because, actually, if you have these mutations, which are the commonest ones, about 80%, glucokinase, HNF1 alpha, HNF4 alpha, the clinical message is, if you've got a glucokinase mutation, you don't need treatment. If you have HNF alpha, 1 alpha, HNF4 alpha, you will respond to glibenclamide, tolbutamide, gliclazide, even gliclazide MR. Doesn't matter. And the key message is that you will respond to not the normal doses we give, but very low doses. Okay? And this is actually, Ewan Pearson published this 20 years ago. Patient with diabetes on glibenclamide, perfectly happy. Somebody came along and said, oh, no, you need to put this patient on metformin. Every type 2 diabetic should be on metformin. What happened? The HbA1c went up, until somebody said, well, actually, you know what? Glibenclamide was working perfectly well. Put him on glibenclamide, HbA1c came down. And I can guarantee you, you have patients in your clinic that you've had on glibenclamide and or metformin for the last 20 years and they're doing perfectly well. Why? Because they likely have this, right? Rather than the standard type 2 diabetes we think about. And in fact, Ewan Pearson then went on to publish a paper in The Lancet that shows how sulfonylureas are so effective in people with, you see the green, HNF1 alpha. So these are MODY. You can see the glucose really falls off with sulfonylureas, metformin, very little effect. The youngest ever reported case of HNF1 alpha mutation, MODY, is actually a 7-year-old. The story is of a father who's diagnosed at the age of 30 with type 1 diabetes. Okay, reasonable. But then, for some reason, because the glucose meter was available, the 7-year-old boy, I don't know whether it was his mother or somebody, decided, let's check your blood sugar, even though he didn't have osmotic symptoms. And they found the sugars were 6.2 to 10.1. So then, of course, you have to do a HbA1c. HbA1c was 7.2%. Has the patient got diabetes? Yes or no? Yes. HbA1c is 7. Islet antibodies, however, were negative, so that takes you away from type 1 diabetes. Mild presentation, family history, negative autoantibodies. And actually, if you do an OGTT, but when they did the sequencing in this patient, HNF1 alpha. So what would you do to treat this kid, this child? What treatment would you give them? Insulin, metformin, or gliclazide, 20 milligrams, right? Tiny dose. And look at the HbA1c, comes right down. The other thing that, again, is back to MODY, right? And again, it's about never say never. Never assume that you have a patient in front of you and automatically they have a particular type of diabetes. And what I'm referring to is, and I see a lot of this in Qatar, overweight children, okay? Now, if you've got an overweight children, what type of diabetes will they have? All things being equal, type 2 diabetes, because they're insulin resistant. This is a study of 3 large population-based studies of fat kids. Age at diagnosis of diabetes, you can see 13 years old. Okay? This is your patient. Overweight, insulin resistant, and has type 2 diabetes. But actually, in this study, what they did is they looked to exclude type 1 diabetes, so they did antibodies. And they found 3,333 participants who didn't have type 1. So they must have type 2, and they must be insulin resistant. But when you sequence them, you find that 3%, 93, actually have MODY. So that, to me, is again a lifetime of potentially insulin and insulin sensitizers that you've saved because you've actually done this test. You thought that, have they got something else? So listen to your patient. He is telling you the diagnosis. And actually, I don't pretend to be clever. I go and I listen to lectures. And sometimes you walk away from a lecture and you think, wow. And I remember this clearly when I was in Manchester. And I went as a consultant, thinking I knew everything about everything. And I went to a lecture from Andrew Hattersley, who is the king of MODY. And I honestly, I listened to his lecture and I thought, wow, this is amazing. And from that day onwards, I have actually changed my practice. So I look at every patient and I think, have they got MODY, right? And this is actually Mr. PS. So this is about a week later. I'm back in my clinic and every patient's got MODY. No, they haven't, right? But so 53-year-old Caucasian man, BMI 21. He'd been actually, at the age of 42, he'd been put on metformin and a DP4 inhibitor. HbA1c didn't really come down. So he got put on basal bolus insulin. But his HbA1c went to 7.3%, but he was having these funny spells. And these funny spells were clearly hypos. What did I do? I didn't do genetic sequencing. I did 2 things. I asked a family history, and the family history was clear, light and day. Yes, my mother got diabetes at the age of 30, and my grandmother got diabetes around the age of 32. So what did I do next? Did I go and genetic sequence? No. this is again is something that you can do. I actually went on I did a C-peptide to see whether it was still producing insulin. And I did do antibodies to make sure that he didn't have type 1 diabetes, and he didn't. It was negative. Then I went actually onto this web, so he didn't have type 1. I went onto this website, and I'd write this down, www.diabetesgenes.org. The reason I would do this is because when you go on this website, there is actually a calculator in there, MODI calculator. And all you have to do is put in the age of onset, what they're being treated with currently, what their HbA1c is, and from that, the MODI calculator will give you a probability of how likely they are to have MODI. And if they've got an 85% probability, you know you don't need to sequence. Just start with them a low dose of glycoside and see what happens. And Mr. PS, actually, I stopped his insulin, commenced him on glycoside 30 milligrams. His HbA1c beautifully fell to 6.2%, and he thought, I'm the best thing ever, right? Because I'd stopped his insulin. But then he told me, actually, his daughter also is being on basal bolus insulin. And at that point, I got really excited. I thought, wow. And she doesn't like taking insulin. So I thought, got to have MODI. Actually, you know, I got caught out there. She had MODI, she had the same gene, but she also had type 1 diabetes because she had antibodies. So I make sure you always check, you don't assume. So the best physician must fail if his treatment is based on a wrong diagnosis. LADA, well, you might think this is uncommon. When's the last time any of you diagnosed LADA? Well, if you believe the literature, you should be diagnosing it a lot more than you think you are. Because if you look at first of all, look at the etiology. LADA is sometimes called type 1.5. Why? Because it's somewhere in between type 2 and type 1. And it's really type 1, but it's a slow autoimmune destruction of beta cells. Clinically, your patient will be thinner, younger at onset, progress to insulin faster, and they will have antibodies. And if you look at the literature, actually, Caucasian populations about 10%. But look at this. This is a paper published now 20 years ago in the Pakistan area, and this is not in a rubbish journal. This is the Annals of New York Academy of Sciences, a very high impact factor journal. 27% of people had LADA. And, you know, we don't diagnose it enough, I don't think. 9.7% in the Chinese. I'll just skip this because it's too detailed. So this again is me having been, I think, listened to a lecture from Leaf Group in the EASD. And he told me that, you know, we're getting it all wrong. It should be more LADA. We're not diagnosing it. So, and then actually Mr. MS comes along. His referral pathway is actually quite unique in that, and I'll come back to this towards the end. So I play football, right? People ask me, how do I keep fit? I play football. But the problem with playing football is that you play with other people, right? And those other people invariably, because I'm a doctor, tend to be doctors. And actually they find it's an easy route to refer people to me. So I have a lot of GP colleagues who play football with me. And they actually say, oh, Rayaz, will you just see this patient? And this was one of those stories. So this was a 35-year-old. He was on metformin, pioglitazone, and this was his HbA1c, 11.6%. And he said, you know, he's got painful neuropathy. You're an expert in painful neuropathy. Will you see him? And I was like, what's his HbA1c? 11.6%. And immediately I was thinking, this guy is not taking his tablets or he's eating lots of food. And immediately you have this vision in your head of the kind of patient you're going to see who's going to walk through the door. So what was that vision? Big, fat, insulin resistant, right? He had all these complications, but when he walked through the door, BMI was 22. We've heard this lecture on obesity. What's the cutoff for obesity? 30 plus. So this guy clearly wasn't obese. So what did I do next? What would you do next? I did an anti-GAD. Why? Because if you do an anti-GAD and he's got LADA, if it's positive, he's got LADA. And actually it was 28.5. So he was positive. He didn't thank me for this, but he does thank me now, right? Because I put him on insulin, which is the treatment that you need for people with LADA. You do not, these are the kind of patients that you've got in your clinic, I guarantee it, on quadruple therapy and still have a HbA1c of 9-10%. And the reason is not because they're not taking the tablets, it's because the tablets they're taking are ineffective. The only treatment that works in LADA is insulin. So HbA1c came down to 7.6% and his painful diabetic neuropathy disappeared. Again, the best physician must fail if his treatment is based on a wrong diagnosis. So this is a quick algorithm of how you might diagnose somebody with something other than, type 2 diabetes or type 1 diabetes. And this is especially if you have a patient in your clinic who are being diagnosed below the age of 30. Okay? So if they're treated with insulin straight away, you measure their C-peptide. If it's less than 0.2, they've got type 1 diabetes. Forget about them. If, however, they are still producing C-peptide, then measure their antibodies. If the antibodies are positive, they've got type 1 diabetes. Forget about them. If, however, they are not treated with insulin and they are antibody negative, then you should do, at least go on the www.diabetesgenes.org and look to see whether they've got MODY or some other form of diabetes. So then I'll finish off with type 2 diabetes. Abraham Lincoln said, all men are created equal. Rayaz Malik asked, are all patients with type 2 diabetes created equal? No. And again, this is part of the problem with coming last in the lecture, because invariably people have used some of the slides. But what I would say to you is, patients with type 2 diabetes are not like type 1 diabetes, where we know that this is a antibody-mediated attack on the beta cells, right? They are complicated patients. They have multiple problems, whether it's the muscle, the liver, the brain, the gut, the alpha cells, the beta cells, the fat. And that's why they all respond differently. And this is a study that's just been published called the GRADE study, which cost $325 million to do. So I think it's worth sharing with you. And what it is gives you a little simple message. And it's all about the patient that's in front of you in your practice who's on metformin, and you need to decide what's the next drug I need to give them. Do I put them on insulin, if you believe what some of the speakers? Do I put them on gliclazide or a sulfonylurea? Do I put them on a DPP-4 inhibitor? Do I put them on liraglutide? Unfortunately, when they started this study, SGLT2 inhibitors weren't really around. So basically, this is the trial design. Around 1,000 patients already on metformin were randomized to either receive glargine insulin, liraglutide, glimepiride, or sitagliptin. And the primary endpoint was very simple. It was, how many of these patients can we get to below 7% HbA1c when we add these medications? And what did they find? They found that glargine and liraglutide were the most effective, glimepiride was next, and sitagliptin was next. Okay, so first of all, efficacy-wise, you can see that the injectables were better. And also, over time, and this is the doses actually, 20 units of glargine, 1.8 milligrams of liraglutide, 8 milligrams of glimepiride, and 100 milligrams of sitagliptin. They also looked at what happens over time, over 4 years, when you've got these people on these different therapies. And what you see is that HbA1c, you can see, falls in all treatment groups. But the blue and the black, you can see, are the best. So these injectables seem to hold the HbA1c better than the orals. Okay? And the same goes And actually, the only other thing that was published shows that if you're on a GLP-1 receptor agonist, your cardiovascular event rate was lower compared to all the other therapies. Okay? So, are there subtypes of type 2 diabetes? What I would say is all patients with type 2D are not created equal. And the reason I say this is because, again, it's like going to that lecture that you think, wow. Sometimes you pick up a paper and you read it and you go, wow, this is something that's amazing. And actually, it's a paper published by Emma Ahlqvist from Sweden, and the senior author on this is somebody called Leaf Group. Leaf Group described LADA 30 years ago. So this is a study that they've done in 2018 where they have challenged that we don't really just have type 1 or type 2 diabetes, not even LADA. What they've done is taken patients, 8,980 patients with newly diagnosed type 2 diabetes. And then they have looked at the body mass index. Are they overweight? What's their age? What's the HbA1c at diabetes diagnosis? And they've done 3 special tests, which is beta cell function, insulin resistance, and then antibodies. Based on that, they actually have been now able to subtype type 2 diabetes into 5 types. And I'll go through these in detail. And what are they? They are, first of all, proportions. You can see, so SED is severe autoimmune diabetes. Despite the fact that they've got supposed type 2 diabetes, these have got an autoimmune problem. Most of them likely have LADA. SID, severe insulin deficient diabetes. This is where the beta cell isn't working, but they haven't got autoimmune destruction of their beta cells. So what could that be? If you've been listening to my talk, a large proportion could be MODY, right? Then you go on to severe insulin resistant diabetes, which is the most we think about. You know, we think about these people with type 2 diabetes as being insulin resistant primarily and then getting in beta cell failure. Then you have MOD, which is mild obesity-related diabetes. And you have MARD, which is mild age-related diabetes. This was in Sweden in 2018. And I remember for the following 2 years, there was nothing but people saying, this is rubbish. We don't believe this. However, come 2023, we now have replicated this, not just in Sweden, Iceland, UK, Germany, China, Mexico, India, Japan. And the reason I'm believing in it is, I used to rubbish it as well, is actually in Qatar, we've just done a big study, replicates exactly the same. So 5 types of type 2 diabetes, what are they? And I put this up so you can actually start to think about these types of diabetes when you see the next patient that comes into your clinic. So severe autoimmune diabetes, around 10% of your patients that you've got, that you think have got type 2 diabetes, they do have type 2 diabetes, but they've got this immune form. They will be relatively young when they're diagnosed, under the age of 30, not overweight, insulin deficient, and they will have autoantibodies, very much like the LADA subtype, but probably additional types now we'll recognize. Cluster 2, severe insulin deficient diabetes, again around 15%. Again, they will be relatively young, less than the age of 30, not overweight, insulin deficient, but they won't have antibodies. And they actually have been shown to have an increased risk of complications. Why do you think that might be? That's because, and what treatment do they need? Both of these actually need either a sulfonylurea or insulin, and they haven't got it. So next, severe insulin resistant diabetes. Here, overweight, insulin resistant, increased risk of nephropathy. Mild obesity related diabetes, obese, insulin resistant, milder disease. Mild age related diabetes, about 50%. Older at diagnosis, that is typically around 50, 60, you're diagnosed with diabetes. Overweight, slightly. Insulin resistant, slightly. And these are the patients that you can manage quite easily with minimal 1 or 2 drug combinations. And this is actually the study that we've just published in Nature Communications, again from Qatar. So 6,000 and odd patients in the Qatar Biobank, and we actually replicate. You can see pretty much same, again, 5 subtypes. Now, if you listen to what I've said, let's go through what you might expect to see for the BMI. So for BMI, the first 2 groups, SED and SID, where insulin is a problem, you'd expect them to be thinner, and they are. SIRD, insulin-resistant diabetes, more overweight. Mild obesity-related diabetes, even more overweight. The older age group, you can see that they've got, their weight is pretty comparable to the SID and SED. What about HbA1c? Well, because we haven't recognized these 2 groups, the first 2, what treatment do they need? They need insulin. But what have they been getting? They've started with metformin, then you've added in a sulfonylurea, you've added in a DPP-4 inhibitor, you've added in an SGLT2 inhibitor. Nothing really works in those. That's why the HbA1c is stuck up there. But the others you can see, again, are better. And then if you look at insulin production, you can see low and high in the SIRD, and then insulin resistant, again, tells you the same story. Okay? So what? If it's SED, SID, SIRD, MOD, or MAD? Well, the so what actually is now becoming clear. And this is a study published of a retrospective analysis of a big study called the ADOPT trial. And ADOPT trial is an old study where they use glibenclamide, rosiglitazone, and metformin. What they've done, and this was in type 2 diabetes, what they've now done, these investigators, is subtyped. Instead of saying all of them have got type 2 diabetes, they've said, okay, what if you've got SID? If you've got SID, severe insulin deficient diabetes, does a sulfonylurea work better? Or is it rosiglitazone? Or is it metformin? And when you look at that, actually, you start to see that there are differences. So SID, you can see the red is sulfonylurea. You get a really good response compared to metformin and rosiglitazone. SIRD, insulin-resistant diabetes, you can see the best response is with metformin or glitazone. And similarly, so now going forward, a lot of trials are going to start to subtype people with type 2 diabetes. So takeaway messages, which treatment for which subgroup? This is where I stop talking and I ask you, the audience. Severe autoimmune diabetes, what is the treatment of choice? Very good. Shabash. Insulin. Not the insulin that the drug companies would want you to prescribe every type 2 diabetes with insulin. But this group, definitely you need to think about insulin. And an SGLT2 inhibitor, because you are not treating the underlying beta, because the beta, you're getting rid of glucose. So SGLT2 inhibitor is perfectly fine. What about insulin deficient diabetes? You sure? Yes. I would say, but actually a sulfonylurea you should also think about. A low-dose sulfonylurea in case they've got MODY. And then you've got a choice of the others. Severe insulin-resistant diabetes? Metformin? Any offers for thiazolidinediones? Yes, we've forgotten about thiazolidinediones. I think 15 milligrams of pioglitazone is perfectly appropriate in this patient. Not the high dose, and not those who've got heart failure, but 15 milligrams works beautifully. So therefore, I would put a TZD there first and then metformin. Mild obesity-related diabetes, well, you can use metformin, you can use TZD, you can use whatever you want, actually, but really start with a TZD or metformin. And at the end, metformin, TZD, DPP-4, and SGLT2 inhibitor. Okay, almost there. This is my penultimate. This is actually, just because I'm from Qatar, we hosted, I say. So when Shahid, you said, was it 25% Pakistani? Actually, I'm 75% Pakistani, 25% Qatari, maybe 5% British. But only because we had this FIFA World Cup, right? And who did you see? I saw Messi 4 times in the flesh. And when I started seeing Messi, I thought, you know, when you watch him, he walks around and suddenly he'll turn and he'll score the goal. Right? So I got, I don't know, enthusiastic about this. So see if you recognize. Is that impressive? Thank you. And Muhammad Ali said, the man who views the world at 50 the same as he did at 20 has wasted 30 years of his life. Thank you.